Okay. So I assume, okay, we're broadcasting now. So welcome to Richmond, Virginia. And it's my pleasure to speak to the fellows in pediatric urology. Despite all that's going on, I think we're in a kind of a good position in terms of the field and specialty. There's a lot of exciting things going on with research. One of the areas that I've been interested in since I was a fellow actually is prenatal urinary tract dilation. And as anything, things evolve over time, and this talk has evolved over time. And the focus of this talk will be, if I can get the slides to advance, will be to discuss the association between kidney dilation we detect prenatally and the risk of infection. Then we'll look at the impact of antibiotics to decrease infection. And then I'm going to touch on the role of imaging with respect to VCUG and frequency of renal ultrasound and the use of renal scintigraphy. So first off, the grading system. So when I started, we used the SFU grading system, which is a combination of a subjective assessment of thinning of the parenchyma, and this is SFU grade 4, and dilation of the collecting system, where if you have uniform dilation and no thinning, it's 3, thinning is 4, and just partial dilation with normal parenchyma represents 1 and 2. The UTD system combined the subjective grading with the objective APD measurement in the transverse plane. So kind of the best of both worlds. So in 2014, I think, or 2016, I forget now, no, 2014, there was a combined multi-specialty consensus statement that included maternal fetal obstetricians, pediatric urologists, pediatric radiologists, and pediatric nephrology. The whole intent was to have a common language. And the question was, if you had a common language, could we still use it the way we use the SFU system, which we know is predictive of renal function, surgical outcome, and those sorts of things. So the setup is that we have a prenatal side and a postnatal side. And both of them assign risk. And based on that risk, there's an evaluation and management that follows. And for the prenatal side, there's only 2, mainly because the obstetricians did not feel comfortable separating peripheral calyceal dilation from more central calyceal dilation, which was the discriminator for the urologist or the postnatal. With respect to the green, yellow, and red, there's a little story behind that with one of my fellows, one of my residents that now is an attending, Matt Timberlake. And in 2010, there was an SFU consensus statement. They kind of had the same message, not the grading system, but in terms of the workup postnatally, but it was all tables. And so with that, Matt was the resident. He said, well, this doesn't make any sense. I said, some of you might know Matt. I said, well, Matt, it has to make sense. You know, it's in English and it's a table. But I said, well, and he reminded me of my adult son. So I said, well, why don't you put together something that you may think makes sense? He goes, well, what if you did this where you assign it green, yellow, and red? And this would be a barometer of temperature. So green would be kind of cold or good to go, kind of like a stoplight. Yellow would be caution, there may be a problem. Red would be stop, we have an issue. And so with that, it was very simple. And I use this with the families when we discuss the kidney dilation. I don't focus on how large the APD is. I just look at the risk. So I say, okay, we're at low risk, intermediate risk, and so forth. Then from there, you can kind of follow them for this pathway. So one of the nice things that came of this consensus statement was defining normal. And so with that, postnatally, we were identifying kids up until this time that had any renal pelvic dilation as abnormal. And then that would warrant a follow-up ultrasound. And a lot of these kids would never come to have a problem. So it was very crucial that we identify normal postnatally. So this is a child that has fluid that is physiologic in the renal pelvis, does not warrant an extensive workup postnatally, and doesn't have any of these other qualifiers in terms of calyceal dilation, parenchymal thickness, and so forth. Incidentally, the prenatal normal values have been around since 1991. So it just took us a while to get to that point. But I think it's crucial to have this. It prevents over-testing, parental anxiety, and those sorts of things. With respect to the remainder of the talk, we'll jump into urinary tract infection. We do know that kidney dilation does increase risk, anywhere from 1 to 2-fold, as demonstrated in this Mansky study that came out in 2012. And their conclusion, although this was retrospective, that high-grade kidney dilation does increase risk of UTI. The question is, does prophylactic antibiotics decrease UTI? Louis Braga looked at about 4,000 infants. This was a systematic review, knowing the weaknesses of systematic reviews. Most of these studies were retrospective. Having said that, he found that low-grade kidney dilation was not impacted by the use of prophylactic antibiotics, both about 2% in terms of risk of UTI. However, if there was high-grade kidney dilation, antibiotics appeared to decrease the infection rate by about 50%. Dan Herz and Paul McGuerian, before they left Dartmouth, looked at about 500 patients retrospectively. In the study, most of the patients, about 75%, were on prophylaxis. UTI occurred in about 17%. It had tended to occur in those not on prophylaxis, although it was not significant. However, if you drilled down and looked at ureteral dilation, this was significant. And this is one of the first papers that looked at that. And they found the threshold of 1.2 centimeters as a threshold to trigger an event that would warrant prophylactic antibiotics. They also found that it decreases UTI 5-fold. Now, the Canadians looked at another systematic review more recently, about 4,000 patients, and they noted that most of these studies were not randomized. However, this was a broader group, and with that respect, they found that prophylaxis did not impact the rate of UTI. In fact, the group on prophylaxis was about 10%. The group without prophylaxis was around 7.5%. But again, there was no protocol here, so it's tough to tell whom went on this and who did not. And remember, all these kids are not discriminately screened with the BCUG. They concluded that the use of prophylaxis was not evidence-based. However, it may have a role for high-grade kidney dilation. Now, we had data from 2 large prospective registries. One is the SFU registry. Rebecca Z, who's now working with me here, was a resident at UVA, put a lot of the work together that I'll present. And then Louis Braga had his registry that he was running at McMaster. Both of these registries, the intent was to look at risk factors for UTI, efficacy of prophylaxis, and the role of postnatal imaging. So with respect to the SFU registry, we looked at about 200 kids over 4 centers, 12 months of follow-up. UTI rate was about 9%. Females, it was about 22%, males only about 3%. Interestingly, despite prophylaxis, a breakthrough UTI occurred in 45% of the group. Significant association with UTI occurred with female gender, circumcision status, and high-grade kidney dilation. Interestingly, 89% of the infections occurred within the first year of life. This may have implications with respect to how long we use prophylactic antibiotics. Factors not associated with UTI were prophylactic antibiotics, prevalence of any grade of reflux, renal duplication, or ureteral dilation. Louis Braga had a similar registry, follow-up around the same, 18 months. Mean age of first UTI was, mean age of the group was 6.1 months, and UTI rate 19%, so a little bit higher. Female gender was the risk factor as well as circumcision status. He did find, however, that prophylaxis, reflux, and ureteral dilation were significant risk factors. So why do these centers differ? Well, as most in the US know, that prenatal and postnatal referrals tend to occur at a much lower threshold than in Canada. So he's seen higher grades of urinary tract dilation, which would be associated with a higher risk of UTI. The higher the grade, the more kids are screened for reflux. Ours had less screening for reflux. And then the inconsistent use or the compliance with prophylaxis. So more recently, we've looked at the SFU registry, and this now involves 6 medical centers, and looking at the primary outcome of UTI with only UPJ-like hydronephrosis. So out of that group, this is very recent data, and 650 patients in this group, most of them males, and about 1/3 high grade or P2, P3. 5-year UTI rate, 5%, so much lower than the other that was just presented. Interesting, prophylaxis had no impact on the incidence of UTI. Females were significantly more afflicted, as well as high-grade kidney dilation. So what's the future of prophylactic antibiotics? Well, it appears that there may be a limited role in reduction with children with prenatal UTD. Reproducible risk factors for UTI include female gender, circumcision status, and high-grade kidney dilation. In areas of future work, which has been submitted to the ESPU, there's the impact of ureteral dilation and reflux. So moving on to lower urinary tract imaging, we do know from work that I did as a resident back in the late 90s that prenatal hydronephrosis is strongly associated with reflux. And if you studied every child that had prenatal hydronephrosis, you would find reflux in about 30%. So when I was in your shoes, that's what we did. We studied everyone because you could find it. And we found that even kids that had resolved hydronephrosis, reflux was present in 25%. So it became pretty clear it was a poor discriminator for reflux. Now, Elizabeth Yerkes, who all of you know, or most of you know, is in Chicago, she was at Vanderbilt as a resident, and they looked at, well, what would happen if you only did a VCUG when they had infections? Would that be deleterious to the patient? And it wasn't. So their group probably had it right with selective screening. And we were probably a little bit too aggressive. Question, is there a role for active surveillance for reflux? Meaning, you know, it's there, but we can follow it. Chris Cooper and then followed by our group in Birmingham demonstrated compelling data that kids with known reflux can be followed off prophylaxis safely. So the question is, can we take a similar approach to a group of patients that we know has a fairly high probability of reflux? Other things to consider are the circumcision status of the patient and the risk factor, the risk of actually having reflux, which is lower than African American females with respect to the role of lower urinary tract imaging. So the picture on the left is a child, this is from Birmingham, this is when you or at least I did. This child had P1 or SFU2 bilateral urinary tract dilation. So fairly minimal, the lowest grade, and this is the degree of reflux that the patient had. There was no ureteral dilation. Now, see, these are kids that if you do not screen, you're going to miss. And so that just is something that you should have in the back of your mind. Now, the question is, well, why don't we want to know about this? Well, the prenatally detected reflux has a completely different natural history than reflux that presents with UTI. This occurs predominantly in boys. Majority of it will be high grade. A significant disproportion will actually resolve within the first year of life, and we think this is related to delayed maturation of the sphincter mechanism and higher pressure voiding. There's a low infection rate, and as stated previously, there's a different natural history with respect to UTIs. So what will be the future of lower urinary tract imaging? Well, I think that we'll be very selective in the use of VCUGs. There's been a paradigm shift towards screening based on risk of UTI as opposed to risk of finding reflux. And I'll pause here because it's very important for the parents and the primary care physicians to understand that this is not a declaration that we don't think reflux is important. We certainly do, but we're basing this on the risk of UTI. So if the patient's at low risk, then we won't look for reflux. And I had this conversation today, but it was about COVID testing, actually, in asymptomatic patients. So it's a corollary there. Do we care about positive asymptomatic patients? I don't think we really know yet, just like we didn't know about reflux 20 years ago. So moving on to diagnosis, which is the most common, is transient. Most kids, as we know, resolve. And if you look at this group, this occurs about 1/3 prenatally and about 1/3 postnatally. And this is work that dates back going on 30 years, so no big surprise. However, what parents wanted to know and what we had very little data on is how quick does this resolve and to what degree? This is work, again, that Rebecca Z helped put together. If you look at grade 1 and grade 2, at 2 years, essentially 100% of patients from the registry have resolved. And if you look at SFU grade 2 or P1, it's about 90% at 4 years. This is not overly surprising, but it's data that the patients want to know. They understand they're at low risk. They want to know, well, how much longer do I need to come back? The McMaster Registry presented very similar data a couple of years ago. In this group, like ours, most of them were boys. The resolution rates, very similar for P1 and P2. Surprisingly, they had about 75% of P3 that would resolve. I think we tend to be a little bit more aggressive in the US with operating, which we have very good success. But it does bring into question, would these kids resolve? Hillary will remember Steve Koff, who did a lot of work when we were residents, and or maybe Hillary was a medical student and I was a resident, but either way, there was a thought that you could watch high-grade kidney dilation. Some of these kids did bounce back and needing surgery later within the first year of life, but I thought about that when I looked at the 75% resolution rate for SFU grade 4. So the future of transient kidney dilation, most patients will be mild, will improve, or majority will resolve. Follow-up will be limited with ultrasound alone, and resolution should be expected in most patients at 4 years. So moving on to UPJ-like kidney dilation, this is certainly the most common surgical entity that we see prenatally. Prenatal kidney dilation severity is a good discriminator of UPJ obstruction as opposed to reflux where it's poor. I think it's important to go back to the basics. This is a Sentinel study by Dillon, and this is Great Ormond Street. For those of you who don't know, is in London, and that's where it's very centralized with respect to the children's care. This is a randomized trial of no surgery versus observation. The inclusion was APD greater than 15 with function greater than 40%. So the kids that have surgery, no surprise, they all did well, and all but one had a decrease in dilation, and all but one had maintained function. The interesting group was the observation group. 12 of these kids maintained function and stable function and stable kidney dilation. 17, it actually got better with observation. And 7 required surgery. Out of that group, 20 to 40 millimeters was the range of kidney dilation, APD. So based on that, several other subsequent studies have looked at targeting a number. And the number that we mainly use is 15 millimeters as an indicator of a patient that may need to be watched more closely. And these are studies by Doug Copeland, and Shami was an MFM fellow in Houston that looked at 12 millimeters in the second trimester, 15 in the third. Zhang et al. Presented this nice study, Journal of Urology, 2 years ago, systematic review of 5 studies, about 1,200 patients, using that 15 millimeter APD cutoff. And they found that it did fairly well with a pooled sensitivity of around 81%, specificity 78%. And the subgroup analysis confirmed that the postnatal APD is better than prenatal, which I think most of us would understand. So what's the future of ultrasound imaging with this group? I think most of these kids can be followed with ultrasound alone. Renal scintigraphy was described in 1993. We thought it would be the panacea. We thought that it would discriminate those that needed surgery from ones that did not. However, it really didn't do that. It confused the picture for some of us. So I personally use this for only the P3s. Selectively, I'll use it for the P2s or provocative testing for the older patient with intermittent UPJ. We know that SFU grade is a great discriminator of function. This was a study in the 2007 by the Chicago group. 33 out of 33 patients had preserved renal function that has SFU grade 3. Whereas if you look at SFU grade 4, only about 75%. So I use this as the backbone of why I have a pretty high threshold for a renal scan. This is a more recent study, and I'll break this down for you. They were looking at, well, if you had SFU grade 3, is it really safe just to follow it without renal scan? So they had 85 kids, 2 ultrasounds, 2 renal scans, follow up around a year. And they had an increase in grade, meaning it got worse, so bumped up from P2 to P3, 12%. The dilation got worse in about a third. So it got worse, but it didn't bump you up a grade. So they had a decrease by 5% of renal function and 17% of the group. And again, that could be 50 to 55, 47 to 42. They did note that renal function was preserved 87% when the dilation was stable or decreased. So again, it increased in 32%. So that's something to hang your head on. If you're following with ultrasound, it appears to be stable, you're probably safe. None of the patients with decreased dilation had a decrease in renal function, whereas 50% of those that had an increase, so out of that 32%, 50% of them had a decrease in renal function. So if you're following it, you need to go ahead and jump on a renal scan if you see an increase. And I think that folds in nicely to what I practice. I tend to follow a trend of ultrasounds, so I might get a little bit more than others for SFU grade 3, but I want to make sure it's either stable or getting better. So in terms of surgical repair, for this group, I don't need to get too detailed, but you do need to understand that all these are successful, anywhere from 97 to 99%. Personally, if I look at my practice, I've revised 4. 2 of them were open, one of those was open, 1 of them lap, and 2 of these robot. And the robot, one was a torsion, where that's where I learned that doing these robotically and you put the hitch stitch, you got to be very careful when you flip up the pelvis that you don't rotate it when you're sewing it together. The laparoscopic was a vicryl that actually wasn't obstructed, but it was a huge inflammatory mass. That's when I quit using vicryl. And then one of the opens was a crossing vessel where the vessel impinged on the UPJ, so I should have put the anastomosis a little higher. But the vessel was impinging. And then the other robotic case was a crossing vessel in a chronically dilated kidney. And I'm quick to jump to a ureterocalicosty in that situation because this, I don't think, drained because it was such a patulous system. But in any respect, looking at time, open without questions faster, followed by robot. Cost, open is least costly. Pain, I think lap and robot do really, once you get to where you're walking, so 3 to 4, I think it really helps. Cosmesis, without question, lap is superior. Some of these open kids I follow that I did, in Birmingham, these incisions are big, and I do a little 2-centimeter incision open, so they grow with the patient. Teaching, without question, with the 2 consoles, it's night and day trying to teach an open through a little incision versus the robot. So Jess Jackson was a resident that helped me put together this practice pattern survey. What I wanted to know is what age were folks doing minimally invasive surgery versus open surgery. So over here, we have 5 months old, 2 years old, 10-year-old, different scenarios. So if you look at open, robot, lap, so these two are minimally invasive, this is open. In a 5-month-old, 80% of folks would do this open, as would myself. My cutoff's 1 year of age. At age 2, 50%. Age 10, still 20% would do this open. I was a little surprised at how high that number was. Reasons why you would do what you did, 47% felt like there was no benefit to a robot, which I could take for a 5-month-old. Even a 2-year-old, no argument there. But in a 10-year-old, I would think that there is a benefit there. So I'd have to push back on that one a little bit. So with that concludes kind of the educational piece. Now I'm going to transition to some cases that I think really hit home why kidney dilation is not always the same. Doesn't always mean it's obstructed. So first case is a newborn, A2-3 prenatal kidney dilation, placed on prophylaxis, circumcised, ultrasound performed at 8 hours of life. Here's the ultrasound: left kidney, right kidney, some dilation, some debris, interestingly, within the pelvis. Bladder's unremarkable. So this would be, you can't see here, but I would call this P2 urinary tract dilation. Had a VCUG that was normal. Left kidney at 1 month looks normal. Right kidney, this is increased. And there's thinning of the parenchyma, and all the calyces are dilated. So with respect to when I see patients at a month versus an ultrasound at 8 hours or 1 day or 2 days for that matter, I tell the family that what you see at 1 month is kind of the real steady state. I don't really believe things increase rapidly at 1 month from 2 days. It may on the ultrasound, but that's because the intravascular volume is so low in a 2-day-old. It's just representative of that. So with that respect, APD here was 16. So this is at 1 month. So I'm not a big believer that anyone needs an operation at a month. I think if you were trained in the 80s, maybe, but I think it's very safe that at a 1 month, you can kind of push things out to 3 months. And that's what I did. I got an ultrasound and renal scan. Bladder, again, remains unremarkable. Right kidney looks about the same with respect to the grading to P3. APD now is increased to 26/16. Left kidney remains normal. So in terms of the renal scan, functions 42%. You can look at the curve here indicates flat curve, right kidney, T1/2. Incidentally, I don't really ever look at that. I look at this curve and I look at the function. Those are the two things I look at when I do a renal scan. And again, I have a pretty high threshold. So I basically get a renal scan when I think I'm going to operate on the patient, just to confirm that. So the purpose would be to prove it's not obstructed, because I've followed these with multiple ultrasounds. So this is a 4-month-old with progressive kidney dilation. And that's unusual, and that's what the group should understand. Most of these kids will get better. So if you see a child within 4 months of life getting worse, that's an outlier. So that should be cause a pause, and you really need to pay attention to this patient. There was a delay in drainage, so we proceeded with surgical repair. This is fairly uncommon. It's very rare to need surgery at 3 to 4 months of age. But in this group, with failure to improve and increase in degree of dilation with decreasing function, I think it's a candidate for repair. Second case, seen at 1 month of age, placed on prophylaxis, not circumcised, prenatal A2-3, similar with respects to what this other patient was. 1 week ultrasound, bladder's normal. Here's the right kidney. Again, I would call this P2. Measurement, APD 21. Left kidney, I would see this is a P1. APD is 8. So we followed. VCG was obtained, which is normal. Another ultrasound was done at 3 months and a renal scan at 4 months of age. So with respect to the function, this is variable. 40% is where I put my hat that it's decreased, not 45. Some will call it 45 is decreased. I'm at 40. Drainage curve, very different than the last case. And you can see just by looking at this curve that it clearly drains. And again, I don't look at the T1/2, but if I did, it's 16, so indeterminate. So I sat on this patient. We didn't have surgery. Bumped it out, another ultrasound. Very similar picture, very similar APD. So I got another renal scan. Look, the function's up to 51%. Now, I know that's not real, but this is the fallacy with all these studies. The whole point that it's not decreasing. And then almost similar picture to the renal scan. So it's dilated, there is some thinning there, but it appears to be draining, and so I'm watching. So the take-home message is dilation doesn't always equal obstruction. And parents, however, should be aware that half of these patients will need surgery. And the focus should be on a drop in function. That should be what triggers intervention. Last patient, a 4-week-old with prenatal kidney dilation. Ultrasound of ECG performed. I don't know the degree. This was a practice that I came into here, so I don't really know the classification prenatally. Ultrasound was performed, and here I would call this a P2 on the right kidney. Left kidney is normal. The VCUG. Now I'll pause here. When I see a VCUG such as this, there are a couple of things. One is that you can see the catheter in the bladder. So if you can see the catheter in the bladder, to me that tells me that they didn't get all the urine out before they put the contrast in. So you should not be able to see the catheter. It should be opacified by the contrast. The second thing is the voiding phase has the catheter in place. And I was going to mention that with the other studies, but I forgot to, so I'm mentioning it now. As we all know, or you may not know, when you have a VCG performed, you really need to have the catheter removed. So looking at this renal scan, maintained function 45%, and there's drainage there, T1/2, 12. So this patient did not have surgery. And at 1 year of age, they were going to have follow-up, and they didn't follow up. And then there's a transition in the practice. And 4 years later, the pediatrician noted that the child never followed back up. So they said, well, you need to go follow up with Dr. Herndon, get an ultrasound. And there was a question because they had never had symptoms. Nonetheless, they did. They came in for an ultrasound. And lo and behold, things have gotten worse, again, without symptoms. So APD now is 53, certainly worse than what it was previously. Dilation, however, looks about the same intraparenchymally. So I got a renal scan because I thought it looked obstructed. Renal function's down 36%. And remember, it was 45% before. So at this point, talking to the family, it was pretty clear based on the drainage, like the previous patient, that there's no drainage. And flat line in the T1/2 is basically 45 minutes or infinity. I'm not sure how I even calculated that number. So we proceeded with a robotic trialplasty, 6-week ultrasound. The patient's doing great. Now, interestingly, I don't get postnatal, not postnatal, postoperative renal scans unless there's an increase in kidney dilation or it doesn't improve after 6 months, meaning if it's stable at the first ultrasound post-op, I don't think that's a disaster. Somebody you need to watch closely. But, and I'm actually sitting on one of those, so I think we're gonna have my 5th redo coming up. And the backstory behind that case, and there's always something different, right? I started doing vascular hitch for the crossing vessel, where you have a crossing vessel. So you basically push everything down, and so that it's not crossing anymore, and you fold the renal pelvis over the crossing vessel. Well, I'd done that on a number of cases, and it was going great. And this was a patient that was not the easiest patient to operate on. So I said, well, I'll try this. And lo and behold, it didn't really look that different at 1 month. It looked a little worse, to be honest with you. And ultrasound in March, it may have gotten better. One thing I focus on is parenchymal thickness. I think that's something that you can look at to see if the APD is about the same. If you look at the thickness and the thickness is getting more thick, then I think it speaks to less pressure and the kidney's getting better. Thickness was a little bit better, but because of COVID and all this, I just put a stent in. And so I'm going to look in the summer, not the summer, in the next couple of weeks and take the stent out and see what things look like. But I kind of feel like I'm going to have to redo that one. And again, every one of these that I'm doing has a little bit different story. So kind of live and learn. So what's the future of UPJ obstruction? I think APD of 15 is a good number to hang your hat. Not you're going to need surgery, but you need to watch those kids. And when indicated, all my patients, I really do offer everything. And I'll do whatever they want. LAP, I don't really have a problem doing LAP. It does take a lot longer to do, but I can do it. And if it's something that the patients want, then certainly we proceed down that road. So circling back to this flow diagram where we look at prenatal and postnatal, I think we do have a lot of data that we can fill in the blanks here. If you look at P1 data from the registries that we both presented, we know these are low risk of UTI. We know they'll resolve in 2 to 4 years. So I think you can easily just have an ultrasound, no antibiotics, no recommendation for a VCG or a renal scan. However, these other grades, it's up to the discretion of the physician. Personally, for P2s, boys, I don't use prophylaxis or give it a VCG. Girls, I would. If I saw a ureter, I would get prophylaxis. I would get a VCG, and for P3s, I do everything. So in summary, we know from the registry data that we have predictable outcomes for UTI resolution. UTIs and resolution for P1 UTD. The role of prophylaxis is still unclear, although it's getting more clear. Recommendations for lower urinary tract imaging should be evidence-based and account for risk of UTI, not prevalence of disease. And risk factors for UTI include female gender, intact foreskin, high-grade kidney dilation, and likely dilated ureter and reflux. And that's it. These are my kids. This one on the right, Oliver, finished college, or is finishing college at home. Unfortunately, he goes to Washington Lee. That's a small private school in the western part of Virginia, obviously named after Robert E. Lee and General Washington. And his brother, that's a twin with Katie, Sam, goes to the same school. And Katie's the one that goes to North Carolina, represented by these two. This is last year's Duke Carolina game that they didn't fold at the end, and they persevered as opposed to this year, which I didn't show the picture, which I didn't go to, but those three got to go to. Finally, this is something that I'm not sure what I'm doing with this, but I think you just kind of scan it and you can socialize something with it. But I think Michelle can help us answer that. But I didn't answer these questions live because I have a component of distractibility, so I'll answer them now, if that's okay. So this is anonymous. How many months would you keep on following a patient with prenatal hydrogen before you operate on them? So I guess you're talking about the SFU3 or P2. This group until they're symptomatic, to be honest with you. And there are protocols where you do renal scans every 6 months. I don't do that. I probably would do a couple of renal scans. If I'm comfortable that the function is not dropping, then I would just follow them. And again, this is not a common group. So this is a minority of patients that we see. How do you size the PJ, what are the references? Oh, so transverse plane. So the kidney and the transverse plane, and the trick is on the ultrasound, you see the hilum, and you know you're right in the middle, and then you measure the transverse plane there within the parenchyma. Don't measure out here where the renal pelvis is, measure in the parenchyma. And I'm sorry for my hands, my residents get on me that I use all the hands to explain things, but it's just easier for me to do. The success rate of vascular hitch, that's pretty funny that you put that in there. I can tell you my success rates, it's either 100% or it's going to be 80%, depending on how this case sorts out. You know, folks that do this say that you give Lasix and you see it decrease. This patient was peristalsing, which should be the parameter you look for. And I know the UPJ was below the vascular hitch. I had one of the other, my colleagues in there, we both affirmed that. Now this patient that I'm speaking to was an older patient, had many episodes of intermittent UPJ, so it may, and had a very thick phlegmon that I had to cut, not phlegmon, but rind of tissue I had to cut through to get down to the pelvis and the vessel. So it may be that it was fine with the vascular hitch and it would have happened anyway, but you had this rind, the tissue kind of kink it. So more to come on that. I'll disclose what happens after that, and I'll let the folks know what the outcome is of those cases. And let's see, I'm gonna scroll down here. Do you make pelvic? I don't do anything on remodeling the renal pelvis. I think that's not data driven. What I do, again, got into my hand. So let's say this is the renal. This is the UPJ. I think it's important to cut it like this and not like this. I cut it like this, so when you put the ureter in, you have a nice lie with that. Again, on the robotic trialplasty, you're gonna pull it to your face, so you have to be careful. And that's that one case I told you where you put the hitch in and you pull it up and rotate it. So when I do that, I'm cutting this at a probably an angle like this, if that makes sense, instead of straight up and down. In which treatment modality you insert a Sally versus a double J? To be honest, I always insert a double J, and part of this is practicality. So I never, in the group, take someone to the OR to take a stent out and it's not there. It sounds silly, but you know, when you have 3 to 4 people and they're operating, oh, the UPJs get stents. I just kind of do that, so that's covered. The only case that I'll do the Sally, and my version is take a feeding tube and cutting it open, is the little babies, like that 4-month-old. I don't put a double J down. I'll put something that goes through the anastomosis, kind of comes out like a Sally, and I'll pull that out at about 5 days. What is your opinion on clearance 30 and clearance upright? So I didn't mention it because it wasn't a renal scan. So what this question, and then the T1/2. So T1/2, I don't really pay much attention to at all. And what I have the patients do with the renal scan is they'll do the 40 minutes. And as opposed to Washington Children's National, where Maj, you know, is kind of the godfather of scan, where they tailor the scan to the patient. Most centers, you get 40 minutes, that's it. So what I'll have done is I'll have them come back at least 20 minutes after the test is done. So minimum of an hour. And, you know, the mom has held the baby and this type of thing. I'll have them lay down, take one more picture, and then you have the 40-minute, and let's say you have an hour and 20 minutes. So then they'll draw a tracer, region of interest around this one, and then around this one, and then compare the two. If they're identical, then that's obviously telling you nothing's draining. If there's, you know, 5% left in this one compared to this one, that tells you it's draining. I did a lot of this in Birmingham. I don't really have any data, but I can just tell you, you kind of know what it looks like when you see it, where it's not draining or it is draining. So that's what I do with respect to upright. So it's called a gastric emptying curve, where they compare the 40-minute to whatever you want, hour and 20 hour. I don't think the time is crucial, that it needs to be specific, except that it's hard to do a research study when you have different times. I haven't figured out how to do that and be consistent, so I never did the study. Probably some mathematician could tell me how to do it. Do you change prophylaxis? How often? At 2 months, I switched from amoxil to Bactrim, mainly because amoxil is very inconvenient for the families. You have to refrigerate it. You have to refill it every 2 weeks. Bactrim is more portable. At 12 kilos, I switched to 25 milligram cap of macrodantin, a half of that, and I do that because the capsule you can sprinkle on there, and half of the 50 or 25 milligrams. You can sprinkle that onto pudding or what have you. The liquid nitrofurantoin is very bitter, and the compliance is very low. So if you were to taste nitrofurantoin liquid, you would understand why compliance is so darn low with that. So use the sprinkles if you're going to use it. Hi, from Brazil. Nice talk, congrats. Thank you very much. Great question. I don't really have a thickness. I compare it to the preoperative state. So right now I'm using thickness as a comparison to post-op. So if that makes sense. So that's Luis Braga, a fellow Brazilian, and I have talked about this preoperatively. Could there be a percent? I think it's hard to gauge because all these kidneys are different. But I do think looking at it postnatally, it really is something there. You can see kids go from 3 millimeters to 10, and APD doesn't change that much, but I feel comfortable. Then those kids over time, the APD does change. Paradoxical hyperfunction, yes, I would agree. When I talk to my nephrologist, they would tell me that hyperfunctioning kidney is what results in is a result of that increased number when you do the renal scan. So that one that went to 52%, but the drainage curve was draining, if you remember. So I'm not sure folks have a good explanation for the hyperfunctioning. That was the same patient that went from 42 to 51, and the drainage curve was the same, indeterminate, and the T1/2 was in the teens. So that kid's not obstructed. That doesn't explain it. So I don't have a good answer for that. And I had two of the, And then from Carlos Rodrigo, would you do early pyeloplasty okay, great question. So the question, this is from Bogota. Basically, what is your threshold to do a nephrectomy for a UPJ high-grade obstruction? And I can say that it's not 20%. I think some of this is based on what the parenchyma looks like when you get in there. Some of these kids have a massively blown out kidney, and I think the function number is really hard to be accurate in that situation. So certainly less than 10%. I think these kids do better long-term with a nephrectomy. And I've actually scheduled one yesterday, to be honest with you, as opposed to doing a pyeloplasty. This patient had contralateral hypertrophy. So I think that confirmed that this was decreased function, because there are some cases where it just looks like it functions more than what the renal scan is saying. I know others that use a higher number, the more traditional number, but I am a believer you got to give the kid a chance. But if there's dysplasia, cystic dysplasia, in addition to P3, and there's contralateral hypertrophy, I think doing a lap nephrectomy is the best way to go. Biomarkers. Okay, I don't have a lot of data on that. We do. I'll give a little little post for our JPU. We are going to have a review article on this that we're expect. So more to come on that with respect to biomarkers, and I think that does have a role. And so certainly that's something that we'll look at, would be more specific to that kidney. I think all these things that, in terms of when I look at these patients, remember all these tests complement each other. So you're looking at multiple ultrasounds over time. Most should get better. If it's not, you put that in this box. Then you get the renal scan. It should show that it's not draining. If it does, and it's not getting better, then operate. So the role of biomarkers, maybe for that SFU3 that I'm sitting on, I don't really know what to do. I certainly know if I operated, they would do fine. So I would never criticize someone for operating on an SFU3 that showed on a renal scan that there was a blockage. Now, I'm completely biased because I wouldn't get a renal scan in that child more than 1 or 2 times. So that one's kind of this mixed bag for me. And we all have those things we're still trying to work on. We all like to have a great, nice, neat protocol. I've got it for the high grade and the low grade, which is most, but I really don't have it for the SFU3. That's just what I do. We do have kids that then become symptomatic. Those kids tend to have a crossing vessel when you go in and you operate. So they may be self-selecting for that. Do you have a renal function cutoff, recommend pyeloplasty? That's the same question. You know, in my head, it varies on what the kidney looks like, but certainly under 10%. 10% again. Same question. Thank you very much. You're certainly welcome. I'm glad you could join us. That's Elias from Mexico, segment of UPA. I do send the UPJ specimen. Sometimes I don't, to be honest, when I cut the pelvis and I spatulate the ureter, I fold that into the repair, so there may not be that much to send because I've moved the ureter up, if you follow me, because it's nice, it's redundant. So I've cut way down here on the ureter. So that's what I'm sewing to the pelvis. So this part gets folded into the more superior part of the repair. So I'll send it if I can. Would you offer VCG for prenatal UTD? If there's a ureter, or it's P3, or P2 in a female. Those are the 3 cases I'm getting a VCG. Obviously, if they think it's valves, I'm going to get it. I'm speaking to unilateral kidney dilation where the bladder looks normal in ultrasound. Then Hector Matato, yes. Yes, okay, yes, okay, great. That, answering his question. All right, and then we have one chat, which I'll look at. Okay, what parameter in terms of failure? Again, it needs to be a lot better. And most cases are gonna look a lot better. I will say I have a bias. I think the kids that have an open pyeloplasty get better, or the first ultrasound looks better than the kids with robotics, in my hands. Now, I showed you that patient that had an ultrasound at 6 weeks, and that looks pretty darn good. But that's why I just stalled. I haven't studied that in detail. But the kids that, in terms of failure, again, it's that group that's not getting better, and that persists at 6 months. Well, you could argue, why don't you get it at 3 months? I can't. That's fine too. And certainly, if they had low function in the beginning, I would get it earlier. So it's the failure for the kidney dilation to improve postnatal, post-op. The thickness doesn't improve. That triggers a renal scan, and that's likely going to prompt you to go in and reoperate. I've told you about the 4 I had, maybe the 5th. None of those did I try to dilate or anything like that. Some people do that. I think it's hard to dilate a UPJ. Usually there's a problem, and meaning it's not how you operated. It's not your technical hands. You didn't have a good day. It's that something happened when you put it back in its normal position to drain. Either it torsed, or there's inflammation from the vicryl, or maybe it leaked and then causes this urinoma and inflammation. So that's my opinion. Hector, many thanks. Thank you. So that's all the questions I have here, and you guys probably know how to find me. I should have my email, which I don't. Hold up, I can give you my email. Give me a second to get out of this. Which I'll type my email right here. So that's my email. Feel free to email me at any time. I got a lot going on, but certainly I'm more than happy to help in whatever way I can, and in whatever venue you need help with. Certainly with this, without question, but if there's anything else, feel free to reach out. So Hillary and Michelle, I'm not sure what, great job, thank you. Oh, that was private, sorry.
That's it, we can wrap it up. I think.
Okay, awesome.
Really enjoyed it.
Thank you for having me. I enjoyed all that. I didn't see everybody. I miss seeing people. Please, I'm going to plug the AU SPU just for a second, if you don't mind, Hillary. We're putting a lot of work into having to have the SPU meeting. We're going to have a virtual meeting. You should be getting some communication to that extent. So the folks that had their abstracts accepted, a number of them, most of them, have submitted their talks with a voiceover. So that'll be virtual, and that can be found when we have it up. It'll be found on the SPU site. And then on June 27th, Saturday, June 27th and 28th are AUA Live. So pre-recorded plenary session and pre-recorded abstracts that were included within those 2 days traditionally. On June 22nd, on Saturday, we're going to have SPU Live. So SPU Live will be the 4 traditional lectures we would have had. After each lecture, there'll be a live question discussion, as if you're at the meeting. And then all the panels that we had planned, we're going to have live for the back half of the day. So I'm a little nervous how that live portion is going to go, but half of it is pre-recorded. And I felt that we needed to kind of dip our toe in the water to trial this Zoom live meeting format. So I hope it goes over well. And I hope that everyone, and this is open to anyone. So you don't have to be an SPU member for this part. We wanted this to reach many as we can. And it certainly may be a segue to a new type of meeting that we have. So again, reach out if you need help with that too. And again, June 27th is the live meeting. And the other we'll have up. You can drop in on that meeting once we get it up at your leisure.